So welcome everybody to the first episode of The Animal Heartbeat. My name is Kieran Borgea. I am a specialist in veterinary cardiology, and I'm here with my friend and esteemed colleague, Novo Matos, who is also a cardiology specialist. We're here to talk to you about veterinary cardiology. So if you're not interested in veterinary cardiology, then you have no soul, and that's fine, but you don't have to listen to us anymore. We're here to discuss a few things today around the topic of feline cardiology. Jose, have you ever learned about heart disease in cats before? Is that something you've ever come across?
Not really. This is really the very first time. Thanks for listening. I'm very excited to record this podcast with you. I love feline cardiomyopathies. We both do, and are by far the most interesting heart diseases we see. So yeah, very excited to talk to you about this topic. Yeah.
And I think part of the interest for me is the challenges that cats present, partly as patients, but also in their heart disease, isn't it? I mean, I'm a novice at this. You have a PhD in feline cardiology. So what do you think are the biggest challenges about feline cardiomyopathy?
Yeah. What I think is very cool, cats per se are very, very good at hiding clinical signs and hiding signs of disease or weakness. And then on top of that, the most common heart disease in cats are cardiomyopathies, which by definition are challenging to diagnose because both in humans, cats, dogs, they have a very long subclinical asymptomatic stage where no one can really detect the disease, neither their owners or vets. And so it's very, very challenging because cats may look very normal and they may have a very nasty and advanced heart disease. So I think that's one of the very first challenges to know which cats might have advanced heart disease and just look pretty normal.
One of the biggest challenges, I think, about detecting heart disease in cats is that often as vets, we focus on the presence of a heart murmur as being indicative of there being heart disease. And I think most vets now understand that's not always true in cats. What's your experience of heart murmurs in cats and how reliable they are as an indicator of heart disease?
So the challenging thing is not all cats with cardiomyopathies will have a heart murmur. And so the fact that cardiac auscultation is completely normal will not exclude that a cat might have heart disease. And
Sure.
So a normal cardiac auscultation does not exclude the disease, which, as you were saying, I think vets understand that and are aware of that. But the crazy thing really is that some normal cats will have heart murmurs. And so some healthy cats will have heart murmurs, which are called physiological or flow murmurs. And so it's really challenging because you may detect a heart murmur, which might be physiological or benign. And on the other side of the spectrum, you may not detect a heart murmur and the cat may still have heart disease. And so murmur grades matters in this case.
Okay.
And so I think what we generally recommend vets to do is to grade heart murmurs, because it has been shown in several different studies that the louder the murmur, the more likely is that murmur to be clinically significant, to be relevant. And so I think the question is not, is there a heart murmur, but more how loud is the heart murmur? And if the heart murmur is louder than 3, it's likely that this heart murmur is relevant and should be pursued. On the other way around, if it is a soft murmur, is less likely to be clinically significant. Would you
and
agree
3,
with that?
yeah, I would. And just to sort of clarify for anyone who doesn't know about the common grading system that we use out of 6, is that 3 would be the same intensity as the heart sounds, the same volume as the heart sounds. So if it's an easily audible murmur that's the same or louder in intensity as the heart sounds, then actually I think we would both recommend following up on that and trying to work out whether there is heart disease present or not. One of the things that I really like about murmurs in cats, and there's a lot to dislike because there are lots of false positives, there are lots of false negatives when you're looking for heart disease or screening for heart disease. But one of the things I like about it is is if we contextualize the murmur in the other points of signalment in that patient, the age, the sex, and even the body condition score, this is something that can be incredibly useful. So I think the work by Rosie Payne and the RVC team in the past has demonstrated very nicely that in apparently healthy cats, and these are largely domestic short hair cats, it's important to say, in apparently healthy cats, if a cat is older and male and a body condition score 6 or above out of 9, then actually that makes it much more likely that the heart murmur indicates hypertrophic cardiomyopathy. And the reason that we focus on hypertrophic cardiomyopathy or hypertrophic phenotype in cats is that that's by far and away the most common type of heart disease that we see in that species. Very, very rare in dogs. Cats are a bit more like humans in that regard, aren't they? Where HCM is relatively common. So I think if I see a grade 3 murmur in a 1-year-old female cat, I think, okay, we've got a murmur. It merits investigation because it is a grade 3. But I'm not so worried about HCM. Now, sometimes I'm wrong about that. Sometimes we do find cardiomyopathy in that patient. But for me, those 10-year-old male, body condition score 6, 7, 8 cats, those are the guys where I really want to take that murmur seriously. And I guess when I've auscultated them, I believe there's HCM present. And what I'm doing with the echo is to look at severity. And sometimes we echo those cases and we find nothing. And we say, okay, great. It is a physiologic flow murmur. But those are the cases where really I'm going into that echo thinking, I believe there's heart disease present. Let's stage it. Let's see where we're at with this disease. Now, obviously, you and I can pick up the echo probe pretty easily because of our experience and training that we've had. But that's not the same case for all vets, is it, in terms of how confident they feel performing an echo? So we've already gone straight to talking about echo. What other options do we have available for diagnostics in those patients? Imagine, back in 2006, I was in primary care practice and I see a cat who's got a grade 3 or 4 heart murmur, 5 or 6-year-old male cat, middle-aged male cat, apparently healthy, coming for routine vaccination. What would your advice to me be as the vet in that scenario? Do you think it's worth me pulling some bloods, for example, and looking at maybe cardiac biomarker results?
Just to stress what you have just said, the problem, also the challenge is echocardiography is the clinical gold standard to diagnose cardiomyopathies. X-rays are not that useful, really. If we compare with maybe mitral valve disease in dogs, that maybe X-rays can help you. They are not helpful with cardiomyopathies, and that's where the challenge starts. Because of course, echo is expensive, is not readily available, and requires experience and expertise, and many clients will not have access to it. So it's important, really, as you were saying, to screen and or to decide which cats really are worse to echo and which cats one should echo or refer for echo. And so what we have just mentioned is really important: signalement and put together a couple of pieces to the puzzle: age, sex, and murmur. So absolutely, totally agree. And then comes biomarkers, and I think biomarkers, and when we say cardiac biomarkers, we are mainly talking about NT-proBNP or cardiac troponin I. Those were the biomarkers that have been more studied and where we have more research data on.
And those are the ones where people can access the tests, aren't they? Where they're commercially available tests.
Exactly.
We might read research about ANP or CMP or troponin T, but these things are you have to buy an ELISA kit and run those manually. If you want to run a commercially available test, NT-proBNP and troponin I are the things to use, aren't they?
Precisely, and especially now that there's a SNAP test for NT-proBNP, so everyone can get a very quick result,
sure,
a positive versus negative result. But to go back to your question, I think, especially as a screening test, NT-proBNP has been shown to be quite useful. Now, what we need to be aware is we should use these tests when we already have a clinical suspicion of heart disease. Because if we just run the test in every cat that comes to our clinic, the test accuracy will be poor, as with any other blood test. So the SNAP test will give us a probability for heart disease, and that's important to explain to our clients. So if the test is positive, in a middle-aged cat with a loud murmur, makes it very likely that this cat will have moderate to severe heart disease. If the test is negative, makes it less likely, the probability is lower for the cat to have moderate to severe. I'm saying moderate to severe because NT-proBNP is not very good at detecting mild disease. So all we can tell to the client is explaining them, okay, a positive test in your cat, where I already have a suspicion of heart disease, makes it likely that the cat will have moderate to severe heart disease. And then we should do an echo or refer for an echo to exclude underlying heart disease. So the test is good as the first screening, really as a screening test in cats with a high positive predictive value, when we already suspect that the cat might have heart disease. And I would just name the reasons for that: a loud murmur, middle-aged to older cat, and potentially overweight, or a familial history of heart disease, or other auscultation findings, such as an arrhythmia, a gallop. Arrhythmia and gallops are way more specific, are way more likely to be associated with heart disease than murmurs. So then if we start putting all that together, this cat has a high suspicion of heart disease, and then BNP will help us, give us that extra confidence.
I think, your point, well, there's 2 points that you said that I think are fantastic. One is about gallops and arrhythmias, because I think if I hear a gallop sound, I almost don't want to run an NT-proBNP. I just want a cardiac assessment, by which I mean an echo. The reason for that is that obviously any blood test, well, any test, in fact, could have a false positive or a false negative result. And for me, if you have a gallop sound, the likelihood of there being significant heart disease is so high that when I get an NT-proBNP result that's negative, I almost feel like it's more likely to be a false negative result in that context. I guess the way it could be a true negative is actually the third heart sound you hear. So ba-ba-bum, 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 rather than the normal lubbed up sound. That third heart sound may not represent a diastolic filling noise, which is representative of high pressure and therefore bad heart disease. It might be a valve click. And I've certainly seen those, I think, probably as commonly in cats as I've ever seen them in dogs. And with dogs, we see it with very early mitral valve disease. I'm still not sure where it comes from in cats. It might just be older cats who have got diastolic dysfunction. It may be they've got a tiny bit of mitral prolapse. I'm not entirely sure, but I think we do hear those third heart sounds in some cats that may masquerade as a gallop sound. But I'm still not keen in those galloping cats to run an NT-proBNP. I think that going back slightly further in what you said, you were talking about probability. That's just so important. And I think it's such an important concept because I come across many primary care vets who will say, I was thinking about starting treatment because the NT-proBNP is high. Whoa, back up the truck. We don't want to treat based on a biomarker. I don't think I can imagine a context where I would give any cardiac treatment based on a biomarker in a cat or a dog or a horse. Do you agree? Can you think of anything where a biomarker would make you treat?
No, I totally agree. I totally agree. And again, I think sometimes we forget that the biomarker, cardiac biomarker, is just a blood test as any other blood test. And so it's just because the test is positive or negative, will not help us at all. We cannot guide treatment based on that. So totally agree. I don't think there is any clinical situation where you would start treatment based on the biomarker. Just to stress what you said, just to go a bit back, a gallop or an arrhythmia is indeed highly specific of heart disease in cats. Dogs may have arrhythmias, which may be caused by systemic disease, and the heart may be normal. But that's very rare in cats. When cats have arrhythmias, the large majority of cats will have heart disease. So totally agree with you. If we detect an arrhythmia or a gallop, we should echo this case. This is a clear-cut indication. But what you said is important. Sometimes I think it's difficult when I discuss with vets and residents. Sometimes it's difficult. Sometimes people struggle to be sure if there's a gallop. The heart rate is very, very fast. And as you were saying, potentially there's other heart sounds, additional heart sounds such as clicks and so on. Sometimes we receive cases which people have detected gallops and there are no gallops or vice versa. So it's not always easy. But I totally agree with you. If you're confident, if you have a lot of experience with cats and you think there's a clear-cut gallop, absolutely echo straight away. If you are not sure, would not hurt to do NT-proBNP. If you let me just regarding your point, because one could say, okay, BNP may not be 100% test, but now let's say that we don't use the SNAP test and we send it to the lab to do an ELISA, and you have a value. And then I would tell you, okay, but the value is 1,200 or more than 1,500, the upper limit of the test. Some people could think, okay, 1,500 is very, very, very high. 1,500, a very high value, has been associated with cats in congestive heart failure or close to heart failure. So cats that had very, very high values had very advanced heart disease and were considered to be in congestive heart failure or very close to congestive heart failure. But a recent study done by June when he was at the RVC showed that SAM, cats without flow tract obstruction, may have very, very high BNPs with a normal left atrium, meaning that just a very high BNP most likely is associated with heart disease, but does not guarantee that this cat has advanced heart disease and is on the edge of heart failure.
And that study was definitely something in my mind when we were talking about it just now. Yeah, I completely agree. And that was a real eye-opener for me, because I think previously I'd thought, oh, if they're super high, I'm really expecting, at least a big atrium and maybe some high filling pressure. But actually, that was a great study, again, from the RVC group, which really highlighted to me that the potential inaccuracy of NT-proBNP. They tell you, if it's that high, it tells you there are some significant changes that you're going to see on the echo, but it doesn't tell you what changes. It doesn't say that they're going to be high risk, and it certainly doesn't stage them, as to sort of B1, B2, C staging system. That the biomarker is really a supportive tool, isn't it? Do you ever use it for monitoring these cases? Let's say we already know they've got HCM and you pull NT-proBNP and it measures 600. So it's well within the sort of measurable limits of the test, but it's above the reference of, 100 or 150 picomoles per liter. What do you do with that? Is that something you ever reach for as a cardiologist, or would you ever recommend monitoring it to primary care practitioners?
So I generally don't use it as a way to monitor heart disease. And why? Because we don't really have data on daily variability. Or good data on daily variability or weekly variability on NT-proBNP in cats, as we have more data in dogs. And so I'm always concerned on what is the degree of when do you get worried? What is the magnitude that BNP needs to increase for us to become worried? So I always struggle with that a bit. And so we need more data. But having said that, sometimes we do, when we have clients that cannot afford echoes for whatever reason, and we measure NT-proBNP when we echo these cats, because then we know, okay, at this baseline times 0, we have these echo findings and the BNP of X, and then give that information to the referring veterinarian. And then it's not uncommon that they will measure then again in 6 months, and then if indeed the value increases, it might indicate that the disease has progressed. But it's challenging, it's really a challenging field, because we do not have data on that. We do not know how big the increase needs to be to be clinically significant or to indicate heart disease. And I'm worried that I will give this false sense of security that will people feel, oh, it's still 600 or 700 and it's fine. The disease has not progressed, and we unfortunately cannot say that. So yeah, I'm not sure. What do you do?
Yeah, I think I remember an abstract some years ago at ACVIN that was presented where the presenter was talking about there being up to a 70% day-to-day variability in that NT-proBNP, which almost makes it useless for monitoring, because it's such a high degree of variability. You'd have to have a case that went from, well, I don't know, I'm not very good at maths. The cat would have to go from 500 to, I don't know, 850 to be a real change. I have used it for monitoring in the past. I think all of us as clinicians, but even as specialists, go through phases of what we consider to be sort of fashionable or good at a time. And when there's no data, we don't necessarily always change our ways. So I definitely went through a phase of saying to people, okay, your cat has a cardiomyopathy with a hypertrophic, maybe I'll just say HCM, phenotype, and a normal size left atrium. So we would say at that point the cat's low risk. And we would normally say repeat the echo in a year. Now, let's say either there are financial restrictions or the cat just said no and didn't want to have an echo performed. And we've had to give a little sedation, and that's challenging. What we'll sometimes do is if we identify those challenges at the time of the echo, we'll pull the biomarker and say, okay, your NT-proBNP measures 500. That's fine. Who cares what the number is, as long as it's within that 1200 or 1400, I can't remember now, the maximum interval of accurate measurement. So we say it measures 500, and we say, okay, well, when you go to your vets next year for annual vaccination, get them to pull some blood. Actually, that might be easier for them to do and less stressful than an echo. So the vet sees them for vaccination, pulls some blood, and if it measures 650, we say, it's minimal change, really. So we don't need to perform an echo again. And they go back the next year and it measures 670, and that's fine. They go back the next year and it measures off the scale. Okay, that's a callback for an echo. And yes, we acknowledge we need to sedate, but actually we've then saved 2 echoes, 2 stressful events. That may be the worst thing in the whole cat's year. So actually, that felt good to me for a while to do that. But I do agree with you. We have a complete evidence vacuum of how to use that. It would be nice to do that in a study, wouldn't it? And actually say how many cats have a heart failure event when we think they're okay. Because actually, if the proportion is very low, well, that's a great monitoring tool. But right now we don't have that data, and actually, I think it's gone out of fashion for me because I've maybe lost confidence in that as a monitoring technique. And I think the day-to-day variability probably is quite high, but I don't know what it is. So I'm telling people this is your callback level, 750 picomoles per liter, but that is something I've effectively decided, and I don't have there's no consensus on that. I don't have great evidence behind that. So just touching on that point of the challenges with echoing cats. How do you approach getting a good echo in a cat? I've recently moved jobs, and I found actually the experience of echoing cats where I am is very different to my previous job. And I think the environment is quite important, and not just the environment where the echo takes place, but the sort of lead in to that echo before we handle that patient. What are your thoughts on that, and what are your experiences?
I totally agree. I think very easily we underestimate how much the environment plays a role. And so if we can optimize the environment by this, I mean, to make the environment as cat friendly as possible, it has a major effect. I totally agree. Starting from the traveling, starting from when the cat travels to the clinic, while the cat is in the waiting room. And then how do we start examining the cat? When do we clip the cat, and so on? And also your nursing personnel or who is helping you. It plays a huge role. So I think people should not underestimate that at all and try to optimize that. Just as an example, we now, whenever we scan cats, we keep the room dark pretty much all the time. We do initially a very brief clinical exam before measuring blood pressure. We will prioritize blood pressure, and then very carefully we will clip them if we need blood. We'll apply amla to try to reduce pain and so on associated with blood collection. So we think beforehand every step that might be stressful. Everyone speaks in a very low voice. We don't want anyone talking loud in the room and so on. We close the room. We close the door to avoid people getting in the room suddenly. And that has a major effect. Totally agree. Major effect. And also to have the right nurse, the right people to help you restraining your cats. It plays a huge role. And in fact, a lot of times we end up avoiding sedating these cats heavily when we improve the environment. But yeah, there are some nice drugs out there now, isn't it? What
for the cats? Nice drugs for the cats. Let's clarify.
Yes, absolutely. Thank you for that. Sure, of course. What do you use to sedate cats or to reduce their anxiety?
I'm quite a fan of gabapentin, and actually the owners giving that before travel, because I think that wind up of travel is pretty bad. And you and I, seeing referred cases, will of course on average see a longer travel journey. We have people come sometimes 3-4 hours to come and see us at our clinic, and that's a heck of a journey for a cat who's a bit worried about being in the car. So what we like to do is actually ask the primary vets to dispense some gabapentin. So I guess we prescribe, they dispense, the owners collect that the day before, and they maybe give a dose the previous evening, a dose in the morning, 2 hours before their sort of anticipated stressor, or an hour before travel. And that definitely helps, I think. If they come to the clinic on the gabapentin and they're still very worried, they're still very anxious, then I quite like using butorphanol. It's a bit boring because anyone who's ever heard me speak on sedating these patients or cardiac anesthesia, I love an opiate for these cases. And butorphanol is nice and cardio neutral. I don't think it does much to affect vascular tone. It doesn't really affect systolic function in a negative way. It might drop the heart rate a little bit because they're less sympathetically driven, but that's okay. And if anything, a slightly lower heart rate in a cat is going to help us get some nice diastolic function measurements on those echo images. So for me, I'm super happy with that. Occasionally, we'll see a cat who is just gone. And they either because of previous negative experiences at the vets or just the overwhelming anxiety of that whole experience, there's just no hope of getting it, even with some gabapentin plus or minus butorphanol. A good example is the hypothyroid cat, who has such a high density of beta receptors because of their thyrotoxic state, and they're so sort of driven and so worried about everything that they're kind of electric and buzzing. That those are the cases where we'll spot them and go, okay, my physical exam is going to be really tough. There's no way I'm getting a blood pressure cuff on that cat, let alone echoing them, with everything being sort of welfare friendly and safe for the cat and for the people handling. So what we all tend to do in those scenarios is actually use an intramuscular sedation, and it's quite deep sedation, and it's a combination of butorphanol, 0.2 milligrams per kilo, midazolam, 0.2 milligrams per kilo, and alfaxolone, 0.5 milligrams per kilo. And we use that in the same syringe. In a cat, it's quite a small volume. The reason we don't use it so much in dogs is because the volume gets very big of the alfax, which isn't very nice for an IM injection. But we'll do that in our very worried cats, very fractious cats, and then once they are, within a few minutes, they get very sleepy. We'll get IV access. We always have some stuff ready to intubate, just in case. I've never had to do that, and I've been using this sedative combo since 2017, so 6 years, and I've not had to do that, but we always prep. I think that sort of is my superstition, I guess, that prevents it from happening. And we give flow by oxygen for those cases, lubricate the eyes because they're quite deeply sedated, and then we'll get a nice echo. And if we need to top up, I find that initial combination generally buys me time enough to echo, but sometimes someone who's a bit slower, a bit less experienced, a bit more thorough, I don't know, they'll take a bit longer, and therefore you need to top up with some IV alfax. And we tend to just do 0.5 mg per kg per top up in those cases. And that works quite well. And they recover quite quickly, and they can go home, a couple of hours later. And the midazolam is quite good because it has an amnesiac effect, so they sort of forget the wind up and the terror of coming to the vets. So it doesn't contribute to that progression of stress and anxiety. If we are going to see them annually for repeat echo, it doesn't mean they sort of remember you torturing them the previous year. And actually their perception of it is just a little better. That's my theory, but I think it does help. So that's kind of my extreme sedation. The common one we use is just gabapentin, and that is pretty cardio neutral as well and very safe for animals. All of these combinations are very safe for animals with even bad heart disease, I think. And the only effect I can think of really on the cardiovascular system to worry about or to think about is the alfaxolone after you top up. Will push the heart rate up a little bit. So I'm just a bit wary about timing some of my measurements. If we've just given a top up of alfax, I'll get some other measurements, and then I'll come back and do the Doppler measurements maybe when the heart rates come down a little bit and that alfax has worn off. Do you have a similar approach?
Absolutely, absolutely. And I think gabapentin, as you were saying, is really a game changer. It helps a lot with traveling. There are some nice data out there showing that has a minimal effect on echocardiographic variables. So very, very safe. And as you were saying, then just to top it up with a bit of butorphanol, potentially alfaxalone, will help a lot, a lot. Totally agree, totally agree. I just wanted to stress that drugs that everyone that does echo and likes hearts hate are medetomidine and ketamine, alpha-2 agonists and ketamine. We would avoid them by all means. Again, there might be situations where one or the other might be useful, but as a rule, we avoid them at all. We hate them really. And so even in a very nasty cat, as you were saying, we should avoid those drugs and try to play with safer options, which are the ones you mentioned.
I think with the alpha-2s, some people use them and say, we gave the alpha-2s and then we found a heart murmur and then we reversed them. So can you echo now? And that's challenging for a couple of reasons, because first of all, alpha-2s will increase preload, they increase afterload, that they drop heart rate, that they'll cause such changes to cardiac dimensions that not only is the echo inaccurate, but they can generate heart murmurs, they can generate mitral and tricuspid regurgitation. So if you detect a novel heart murmur in a dog or a cat that's sedated with an alpha-2, forget about it and auscultate them when they're, a few days later, when it's all out of the system. The other thing is that whole, we reversed it with the atipamezole and can you do an echo now? Because the animal's quite conscious and awake and looking at us. Well, the problem is that we know from some data that's out there that it takes about 36 hours for the echo to normalize even after reversal. So once you put alpha-2s in the same postcode as these cats or dogs, you can forget about an echo today or tomorrow. And most cardiologists are going to say, come back in 2 days and we can have a conversation about what the heart actually looks like. So I think that's probably an important thing to consider if you are using this sedative in combination for other work, for orthopedic radiographs or something. Just don't focus on these newly detected heart murmurs. Come back when there are a couple of days post sedation and review the situation then. Now that we've had a think about heart murmurs, cardiac biomarkers, and how to facilitate performing an echo, it's time for a break. This is a two-parter episode. There's so much to say on these early stage cardiomyopathies in cats that we're going to have a second part to this discussion where Jose and I are going to be talking about phenocopies, things which masquerade as hypertrophic phenotype cardiomyopathy. And we're going to think about how to stage cardiomyopathy and how to identify cats in the asymptomatic phase of cardiomyopathy that may benefit from treatment. So be sure to listen to that podcast to finish off this topic of cardiomyopathy in apparently healthy cats. And the discussion on managing heart failure is a whole different topic. And perhaps we can get a guest in to discuss that with us. So be sure to join us in episode 2 of The Animal Heartbeat, and we will look forward to seeing you soon. Welcome to episode 2, or rather part 2 of episode 1 of The Animal Heartbeat, a podcast on veterinary cardiology hosted by him, Jose Novo Matos, and me, Kieran, both of us cardiology specialists, both of us budding podcast enthusiasts. If you're interested in veterinary cardiology, this is the place for you. So our first episode on feline cardiology ran a bit long. We've got a lot to discuss. So what we have done is separate this into a second episode, focusing on apparently healthy cats with heart disease, thinking about echocardiographic findings and what they might mean for the cat. Obviously, we've talked about echo, and I don't think it's really the focus of the conversation today to talk about the different phenotypes that we have, the sort of HCM, RCM, DCM phenotypes. But I think it's worth saying, talking a little bit about HCM and about left ventricular hypertrophy, because it's just so common to find it in these cats that we're echoing with incidental murmurs or suspected cardiovascular signs that I think it's worth focusing on. And obviously, when we talk about a hypertrophic phenotype, what we mean is that the left ventricular wall thickness is increased. What's your perspective, Jose, on hypertrophy in cats? So is all hypertrophy that we see on an echo, is that all HCM? Are there different causes of that we might expect and that we might need to think about ruling out in these cases?
Exactly. That's an important topic. And that just stresses how interesting HCM is. Because you see, if you have just, the disease is already challenging to diagnose per se. And then there are disease mimickers, HCM mimickers, diseases that mimic HCM. That's why it's way more interesting than boring mitral valve disease. Because you scan, there's mitral valve insufficiency, great. Okay, you can come up with some fancy echo stuff, but that's it. Not with HCM. So
I'm just going to step in to rescue the reputation of a future podcast episode where mitral valve disease is going to be a fascinating topic. But maybe we can edit this bit out. But I think feline cardiomyopathy definitely poses more challenges and more food for thought in terms of what our diagnosis is and what our prognostic indicators are compared to mitral valve disease. I completely agree with you about that.
But as you were saying, it's really important. So when we echo a cat, or we read the echo report and we see that there is left ventricular thickening, thick left ventricle walls, we should not call that straight away HCM. A nice approach that the most recent ACVM guidelines have taken, mimicking the European Society of Cardiology approach to classify cardiomyopathies, is to define the echocardiographic findings as phenotypes. So that means we scan a cat and we detect thick left ventricle walls. So we'll call it HCM phenotype. This means that this heart looks like HCM. We are not saying that this cat has hypertrophic cardiomyopathy, familial genetic hypertrophic cardiomyopathy.
And that's an important distinction, isn't it?
Exactly. And all we are saying, it looks like HCM. And this helps also to discuss the case with colleagues and clients. People understand, okay, this looks like HCM, meaning the walls are thick. Great. And then we need to stop and step back and think, okay, what are the causes of increased wall thickness? And the low-hanging fruit will be increased after load. Systemic hypertension will cause left ventricular hypertrophy. So we should measure blood pressure in these cats to exclude systemic hypertension. Of course, measure blood pressure in cats is very challenging and so on, maybe a bit beyond what we are discussing here today to discuss how to measure blood pressure, but it's really important to exclude systemic hypertension. The next common or potentially important cause of left ventricular hypertrophy is hyperthyroidism. So hyperthyroidism can cause left ventricular hypertrophy. And these two conditions are really important because they affect the same age group as cats with familial HCM, as we were saying earlier on this episode. So HCM, familial HCM, has something called an age-dependent penetrance. Is more likely that cats would develop the phenotype as they get older. And again, also the same happens with hyperthyroidism or systemic hypertension, affects mainly middle-aged older cats. And so this means that then we have three conditions that affect elderly cats or middle-aged cats, and we need to exclude those once we detect hypertrophy, especially because systemic hypertension and hyperthyroidism are easily treatable conditions, which HCM unfortunately is not. There is not a specific treatment for HCM. So it's really important to, first of all, detect those conditions or try to exclude them because they may mimic HCM. So those are the two first differential diagnoses that we should all have and exclude. I just wanted to say before we discuss further phenocopies or HCM mimickers, of course, the challenging is that a cat may have HCM and systemic hypertension, or may have HCM and hyperthyroidism. Because if we have just said that these conditions are so prevalent in elderly cats, the cat will not just choose to have one or the other. So it's likely that cats may be affected by both. And that's okay. And you may, with more experience already on echo, have a high suspicion that this cannot be only systemic hypertension or only hyperthyroidism. And the walls look thick, asymmetric, very heterogeneous. Different segments are affected by hypertrophy. But nevertheless, if a cat has hyperthyroidism or systemic hypertension, we will need to treat those, because that will affect afterload, will affect cardiac remodeling. And so hopefully, even if there is a background, if the cat has HCM on the background, by treating those two conditions will help to have some degree of reverse remodeling. So those conditions are really important to detect and treat when present.
I remember one very, very sort of memorable case from my residency, where it was a cat that had come for radioactive iodine treatment for its severely uncontrolled hypothyroidism, and he presented in heart failure. So he had huge left atrial dilation, and his heart rate was consistently incredibly high, really massive hypertrophic phenotype on the echo. So we gave diuretics, we treated the heart failure, we started clopidogrel, for his ATE risk. So all these things that I think we're pretty comfortable doing. And then we treated his thyroid disease medically. So we basically started him on some topical methimazole, I think. My medicine on thyroid disease is a little rusty. And he hugely improved. Whether he was just grooming that off and eating it, or it was working transdermally, I don't know. And then actually he stabilized quite well with that. But radioactive iodine is the best treatment for those cats. And we decided that, okay, with radioactive iodine, are we going to put him in isolation for 3 weeks because we can't handle him for health and safety reasons, and risk that he's going to go into heart failure, after his sedation for his injection? Or are we going to accept that his thyroid disease may or may not be perfectly controlled, and that will impact his welfare in many ways, one of which is it'll make his heart failure worse because of the volume loading effect and the cardiovascular effects of the disease? So the owners decided that they wanted to go down the road of let's try and treat definitively. At least then we get rid of the thyroid from the equation in most cases with radioactive iodine, and we'll see what's left with the heart. And they were not too risk averse. They were comfortable with that. And he was taking oral medication very reliably in food. And that's really important for those cats. So he was sedated with that combination we talked about before. He had his radioactive iodine injection. He went into isolation. Did fine, respiratory rate was fine, took his meds, behaved himself, everything great. And we echoed him just before he went home. We had a quick sort of peek and shriek look. Actually, his left atrium looked all right. It had come down in size. We were quite impressed with that. So we saw him back 3 months down the line to see what his heart was looking like. Euthyroid, doing brilliantly, still on diuretics, but quite a low dose. And on his echo, his left atrium was a normal size. It was measuring 15.5 millimeters or 16 millimeters in long axis, which is great. That's top end of normal. I'm happy with that. His left ventricle was a real mess. It was still hypertrophic, huge papillary muscles, end-systolic cavity obliteration, outflow tract obstruction. There's no doubt he had this typical hypertrophic or HCM phenotype. These sort of other echo features of HCM were there too. But his atrium was a normal size. So we weaned out his diuretics to stop them completely. So he came off his diuretics. He still had HCM. But the thyroid disease was what had tipped him into heart failure. That's what had shortened his life expectancy and given him those negative prognostic indicators. So we'd aggressively managed the thyroid disease. We'd taken that risk. It was a bit of a roll of the dice, but it was absolutely the right thing to do for that cat. So for me, heart failure is not an exclusion for radioactive iodine treatment or trying to treat. So long as all parties, the owners, the vet, everybody knows that, maybe it doesn't go that way. Maybe they are too far gone, and maybe the risk is a little bit higher than we'd like it to be. But that case really emphasized to me the importance of try, because actually he did great. And that was a big lesson learned for me, I think. What's your age where you start thinking about, okay, this cat's got a murmur, I've echoed it, it's got HCM or an HCM phenotype, I'm sorry. When do you start thinking, okay, this cat's, 5? Do you measure BP, worried about systemic hypertension in those cases? Do you run a thyroid panel in those guys? How do you approach that? Do you have any sort of cutoff values, or do you just test every cat with an HCM phenotype?
Exactly. No, we generally use a cutoff of 6 years of age, because that's what the guidelines have suggested. and also looking at feline cardiomyopathy guidelines, and also looking at ACVM systemic hypertension guidelines. That sounds a reasonable cutoff. But that's what generally we do. But again, we are not very religious about it. I think it would be fine if someone would say, well, I would like to measure it before a bit younger or a bit older. What I think is really important about that is we diagnose now systemic hypertension and hyperthyroidism at the very early stage. In comparison, we vets, in comparison what we did 25 years ago.
Oh yeah, if you look at all the Phil Fox research from 1990, 1993, that sort of era, it's very different, isn't it? The cats who were presenting hypothyroid were way more advanced than they are now, which is great.
Exactly. Yeah, exactly. So that's why also we would not see like classic cases where hyperthyroidism has caused very, very thick walls, or systemic hypertensive cats who have very, very thick walls just caused by those two conditions. But so having said that, but as these diseases may markedly affect LV morphology, especially in a cat that might have HCM already, I think it's really important that we try to detect them as soon as possible, as early as possible, and try to address them. So 6 years of age, but to answer your question, 6 years of age is generally our cutoff. And again, just as we are talking about these, just to remind everyone that blood pressure, systemic hypertension is very challenging to diagnose in cats, because we have just mentioned before how stressed, anxious they are in the clinic and so on. So to diagnose, we need to be careful and not overdiagnose systemic hypertension. Having said that, we need to take serious any high blood pressure measurement we have in a cat. I think the ACVM guidelines on blood pressure, systemic hypertension in cats, published at JVM, are very nicely written and they suggest a very nice protocol on how to address cats with high blood pressure, different cutoffs, depending on how worried we are about end organ damage. I think I would recommend everyone to read those guidelines and follow their recommendations, but just remember that we need to be careful in one hand, because we may have something called white coat effect or stress situational hypertension, which may mimic systemic hypertension. But on the other side of the spectrum, we should not underestimate high blood pressures in cats. But I look at those guidelines because they are very nicely written and give very nice practical tips on how to approach these cases.
And one thing that I quite like doing in those cats is actually a fundic exam. So looking at the retinas. I'm not going to pretend I'm great at it, but I think just to get an idea of, does it look like, if we've got some hypertrophy on the echo, we've got a BP of, I don't know, 195. I think if it's 230, all right, I think we probably believe it's real. I'm not sure white coat, or in my case, blue scrub top hypertension goes that high, although maybe it does. So I'm still a bit wary. But I think if it's 195, 200, I really want to get a fundic exam on those patients. I don't necessarily dilate the pupil. I think the cat doesn't love that, and I'm not the best at fundic exam. But if an ophthalmologist probably will want to do that, and if you've got time and a bit more expertise, maybe you do want to do that. But I quite like just to have a look to see, are the blood vessels tortuous looking? Is there any hemorrhage, any sort of punctate detachment or anything? Where you won't see it grossly looking at the eye, like these terrible hypertension cases. I got full retinal detachment and uveitis and things. But just these more subtle changes that even a novice like me at fundic exam can identify. So that would help swing my decision. Do I treat now, or do I get the primary vets to remeasure that, or do I remeasure that myself in a few weeks? Maybe we can get a gabapentin on board, bring them straight from the car straight to the consult room, no sitting in the waiting room, no winding up and getting a BP then. And I think that can be very helpful. So you mentioned about the sort of hypertrophic phenotype and ruling out other differentials for that. Obviously, if we do have systemic hypertension or hypothyroidism, it's something where we can try and get on top of those diseases. We can reassess the heart. Are there any patterns of cardiomyopathy in cats where you identify it and you say, actually, this is benign, or this is something that I'm not worried about? Do we see different prognoses for different patterns of hypertrophy or different echo changes?
So that's a big area, something that hopefully we will learn much more in the next 10 years or so, I hope. That's an area that I like very much, and I'm sure many other centers are working on that, which are patterns of hypertrophy, as you were saying, and also other diseases that may mimic HCM and may have a better or worse prognosis. Depending on the pattern of hypertrophy, if you look at the pattern of hypertrophy, a form that is generally considered to be more benign is when hypertrophy only affects the most basilar part of the septum. People have used different names to describe that basal bulge, basilar hypertrophy, both in human and veterinary medicine. I like acronyms. So DUST, I think, is a very cool acronym.
And I'm a massive fan of the Philip Pullman books, the His Dark Materials. I don't know if you know them, but DUST is something that features highly in those. So I'm a huge fan of DUST as an acronym for discrete upper septal thickening.
Exactly, but exactly. So, but people can use, of course, can describe it differently. But so for the ones that are not aware of this pattern of hypertrophy, is when the most basilar part of the septum is thick. This is a phenotype most commonly seen in elderly people, also believed to be most commonly seen in elderly cats. And there's only one study that has looked into outcome. Is an abstract, is in the form of an abstract, but has shown that the outcome in these cats is very, very good, and in humans has an excellent prognosis. So when the hypertrophy is just very basilar, generally is associated with a good prognosis, and these cats do not go into congestive heart failure. There's a big debate on how to call this. Is this a mild form of hypertrophic cardiomyopathy, or is this just an age dependent change due to the angle between the septum and the aorta, the so-called aortoseptal angle?
It's something we see in those dogs, isn't it? With subaortic stenosis, we see changes in that region related to aortoseptal angle, and I think that's interesting. Is that happening? Are there genes out there that cats have which become active with age? That sort of give them the substrate for developing hypertrophy, and then cats who've got a little steep or acute aortoseptal angle, those guys are more likely to get some hypertrophy in that region, but they don't have other risk factors, and therefore they don't get what we would normally refer to as a sort of classic HCM phenotype or hypertrophic phenotype. I have to say, if you'd asked me 5 years ago, I would have said any hypertrophy is HCM. So I would have said, okay, you've got hypertrophy in the basilar septum. Yes, that is HCM. This is something we need to monitor. I would have classified it as I classify everything else. I would have said, anecdotally, in my experience and that of other cardiologists, we see that as a relatively benign pattern. But I wouldn't have called it something different. And I think actually using a separate descriptor for it, like DUST, or basilar bulge, or whatever you want to call it, rather than saying HCM, I think that changes how we think of it, and it communicates that it probably is something a bit different. So I think for me now, I'm a lot more relaxed in my conversation with an owner if I just see that discrete upper septal thickening than if I see discrete free wall thickening, for example, or massive papillary muscle hypertrophy. They're very different conversations I have with an owner, rightly or wrongly, because there isn't a consensus statement on this at the moment. There isn't, great long-term outcome data. But this is something that, with experience, I think I've triaged based on hypertrophy pattern. And these are the nuances, I think, of feline cardiology that we're all coming to understand, and maybe in 5 years' time, again, I'll listen back to this podcast and go, I did not know what I was talking about. I was so wrong about that. Yeah. It's an area of evolution, isn't it, in our understanding? And that's one of the neat things about veterinary cardiology, actually, generally, is there's a lot of active research and a lot of open-minded sort of discussion on these various topics. So I think with the discrete upper septal thickening, I'm fairly relaxed about those. Do you have any other advice for either primary care vets or anyone out there who wants to develop their feline cardiology experience? Any advice for prognostic indicators on echo, or generally any prognostic indicators that would help guide our conversations with owners, with carers of those cats diagnosed with a hypertrophic phenotype?
just to say that we have just mentioned dust or basilar bulge, and in fact, that's one of the exceptions where we can say that a specific pattern of LV hypertrophy is probably benign.
Okay.
Because otherwise, the degree of hypertrophy has not been shown to be associated with prognosis, except in extreme cases. So Rosie Payne, again, while she was at the RVC, has shown that extreme hypertrophy, meaning wall thickness above 9 millimeters at 10 diastole, was associated with a low prognosis. But was not was not the factor, the variable that had a higher risk or odds ratios in comparison with other factors. So hypertrophy doesn't seem to matter that much.
And that's a bit of a misconception, isn't it, amongst practitioners? I have people say, "Oh, the left atrium was normal size. Oh, but the free wall measured, 9.5 millimeters or whatever." Or sorry, maybe that is an example of a prognostic indicator. People say, "Oh, it's very hypertrophic." But the left atrial size was normal. I'm really worried about this case. Think it's on the brink of heart failure. But obviously, you or I would look at that and go, "Okay, well, let's come back to the left atrium, because that's going to be our barometer of risk in that particular patient, and we're less worried about the hypertrophy."
Exactly. So hypertrophy is important to document and define and diagnose the disease, but then hypertrophy per se would not tell us how likely is this case to develop complications. And it's just important to stress that hypertrophic cardiomyopathy, in fact, does not mean is not a bad disease all the time. And that's a really important concept to explain to clients. Similar to humans, in fact, the majority of cats with HCM would not suffer any complications. Several different studies have shown that around 30%, so 1/3 of cats, would develop serious life-threatening complications, such as congestive heart failure, aortic thromboembolism, or sudden cardiac death. Up to 70% of cats may remain asymptomatic. And that's important to explain to the clients when we detect hypertrophic cardiomyopathy. We're going to need to be more careful with these cats whenever they undergo general anesthesia, they need fluids and so on. But many cats will remain asymptomatic all their life. And that's important. And that brings the left atrium into equation, as you were saying. So the left atrium is really probably, to measure the left atrial size, is one of the most important measurements variables to do on echo, because this would tell us if there is increased filling pressures and how high is the end diastolic pressure, and what's the risk for the cat developing congestive heart failure, ATE. So for any practitioner out there, I would try to get very good at measuring left atrial size and have a feeling of what is normal, moderate, or severe left atrial enlargement, even without measuring it. And so I think left atrial size is by far the most important echocardiographic variable in cats and probably also in dogs to assess what's the risk of complications associated with their heart disease. So just to repeat myself, I think first you want to diagnose the cardiac phenotype, and you may define, depending on what you find on the left ventricle wall thickness and systolic function and so on. But then what we really want to know is what is the left atrial size. So what we really want to know is this a stage B2 cat, a cat with large left atrium? Because those are the cats that we truly want to identify. That's the red flag, left atrial enlargement, because we need to be careful with traveling in those cats, stress, IV fluids, general anesthesia, because these are the cats that may be pushed into congestive heart failure, and the clients and the vets need to know that they are a bit like a ticking bomb. They may at any moment decompensate. So left atrial size would be my number one risk factor, or left atrial dilation.
Yeah, it's definitely our sort of go-to. If we're unsure about anything, we always go back to the left atrial size. And I think that's a big deal, isn't it? So I think, there's so much to talk about in feline cardiology and cardiomyopathy that I think, it's a whole future podcast episode to talk about heart failure and how to manage those cases that are either the highest risk or the history of heart failure. But I think just as a final word on the sort of preclinical cardiomyopathy and diagnostics and decision-making in those preclinical cats, let's focus on when to treat with clopidogrel. because the consensus statement from ACVIM, which is a fabulous document talking about the staging system, A, B, C, D, and B1, B2, B being preclinical, B1 being normal left atrial size or normal left atrial size or mild left atrial dilation, importantly, and stage B2, which is the cats where clopidogrel treatment is indicated because of a higher risk of ATE events. They are classified as moderate to severe left atrial dilation. You can see where I'm going with this question. What's your cutoff as a feline cardiology expert for moderate to severe left atrial dilation? Because the consensus panel didn't write a cutoff, probably because they couldn't agree, which is fine. But how do you interpret that?
Yeah, I guess one of their aims was also, as there is no data really showing what the cutoffs should be, and then qualitative assessment is incredibly important, and that's important also to anyone that is starting scanning, echoing cats. Maybe at the beginning they should not be too worried about measurements, because every measurement is prone to error, and you need to have very good images and so on to measure it properly. So the qualitative, if it looks big, it's big. If the left atrial looks big, it's big, and that's when you should start treating. If it is like you are not sure, it's probably not that big. So I think that was always I think the take-home message from the guidelines. But generally, clearly putting my neck out there, I use left atrial diameter, long axis diameter of more than 18 millimeters as moderate enlargement, and LAEO more than 1.8. Why I do that? Because I think sometimes left atrial diameters in normal cats may reach 17 millimeters. Depending if your image is not perfect, and you might be getting a bit of the left auricle. Mm-hmm. And LAEO between 1.6 and 1.8 is, to me, mild enlargement, and so that's why I generally use 1.8 and 18. What's your cutoffs?
Yeah, it's interesting. I think I find that they can give me quite a different impression, those long axis left atrial diameter versus left atrium to aortic root ratio. And I always think that's because the left atrium aortic root ratio is a compound measurement and therefore is more prone to error. So if I'm in doubt, if I get an LAAO that looks normal, but I get a left atrial absolute diameter in long axis, maximum diameter of more than 16, I think I believe the long axis diameter. I agree with you. If you're slightly oblique and you're not sure sometimes, that you are, then you will overestimate that long axis diameter. So I think I agree. 18 millimeters plus is definitely abnormal. 60 millimeters I would call top normal, but I certainly wouldn't make any treatment decisions based on 16 or 17 millimeters diameter. And I think the advice I tend to give practitioners is actually really an LAAO of 1.75, which I guess is the same as yours, is 1.8, isn't it, if we round up? And so I think 1.8 is a good cutoff for the LAAO measurement. Long axis diameter, I have a harder time with deciding when to treat based on that. And actually, in my own cases, if it's not a sort of advice case from a general practice vet who's contacted me, if it's my own case, I really take account of left atrial function, and I looked at left atrial fractional shortening. So I think if I've got an LAO of 1.7 or 1.75, but my left atrial fractional shortening in M mode, in that same view as the LAO, is I guess 15%, less than 20, then that's a problem for me. I'm sorry if you hear a noise in the background. My dog has just joined me for the podcast recording. She's protesting against a topic of feline cardiology. The cat, being a cat, typically is absent. So do you measure the left atrial fractional shortening? Is that your approach?
Absolutely all the time. We measure that as a default measurement now. Very easy to do. Again, I don't think for people working more on left atrial systolic function, you may argue is not a great measurement of global left atrial function and so on, but it's very easy to acquire. And so it's something that we do all the time. And I totally agree with you. We look more into left atrial systolic function. And we also look into left atrial systolic function or fractional shortening to decide when to treat. And so that's important. I just wanted to not sure how much time we have left, but there was an HCM phenocopy that we did not mention yet.
Oh yeah, and I feel wrong about having not mentioning this because it's a really important topic. Yeah, absolutely. You know what? Let's make time for it. We're our own masters, so let's discuss this because this is an important thing to think about.
So what we are saying here is, so when we were discussing HCM phenocopies, diseases that mimic HCM on echo, we mentioned systemic hypertension, blood pressure. And just please let me quickly add that acromegaly is also a differential diagnosis for HCM phenotype, especially if you have a diabetic cat. A dehydrated cat, the walls may look thick, which is called pseudohypertrophy. So those are other important differential diagnoses for
and of course congenital heart disease like subaortic stenosis, or you know, these are all, it's all a hot topic, isn't it? Yeah,
absolutely. But then what we were mentioning too was a work that we collaborate, Kieran and I, with other cardiologists across the UK in Europe, where we describe a condition called transient myocardial thickening, which the name says it all, which are cats that are presented into congestive heart failure, cats that are presenting acute congestive heart failure that on echo, they look like HCM, the walls look thick. But then over time, the wall thickness may normalize and they have reverse remodeling, and the heart may normalize and go back to normal. Hence the name transient myocardial thickening. It is a bit questionable what is the cause for this transient wall thickening. Certainly is a very acute process where the left myocardium is suddenly abnormal, and which cause the cats to develop congestive heart failure and over time may normalize. So the most likely causes for this condition are either acute myocarditis. So myocarditis in humans, acute myocarditis causes myocardial edema. And something that is really important to remember is when we echo a cat or dog and the walls are thick, this does not always mean hypertrophy, means increased thickening. Increased thickness. And so on echo, we cannot really differentiate between hypertrophy and myocardial thickening caused, for example, by myocardial edema. And so these cats most likely have some degree of myocardial edema plus minus inflammatory cell infiltration that cause the walls to look thick on echo, and then they normalize over time. So it could be acute myocarditis. What is funny about these cats is the majority of them before presentation had a stressful event, an antecedent stressful event, which can be a different sort of things. They may have undergone castration, standard surgery for castration, spaying, or more serious stuff like a road traffic accident, or they were just not well and they went to the vet, or the owner left them in a cat shelter for some time.
That's the one that I remember really well, because that was one of the cases I contributed. Was a cat whose owner, actually she was or is a vet, the owner of this cat, and she went away for the weekend. And the cat went to the cat shelter or the cattery, and that was enough of a stressful event to trigger this cataclysmic heart failure event.
So exactly. So antecedent stressful events were common in these population of cats, or are common triggers apparently of this condition. So one option is acute myocarditis. Cats suffer acute myocarditis, myocardial edema that pushes them into congestive heart failure. The other option is something called stress cardiomyopathy. So in humans, there's a very important type of cardiomyopathy called Takotsubo cardiomyopathy or stress cardiomyopathy, where people that undergo severe physical or emotional stress may be pushed into congestive heart failure and may be affected by a type of cardiomyopathy called Takotsubo cardiomyopathy. So we're not sure yet in cats if it is more myocarditis or the stress cardiomyopathy, but what is really important, and we wanted really to stress that in this podcast on feline cardiomyopathies, is that some cats may have a transient form of heart disease, and this seems to affect mainly young cats with a stressful event. Not every cat to be young or have a stressful event, but these are the two classic red flags. But what is really important, and we want to stress, is, to me, the take-home message is treat every cat with heart failure if you can, because it's very difficult to predict how will the cat respond to heart failure treatment. And some cats may have a transient form of heart disease, and in this case, every cardiac drug may be stopped later on, and the cats are back to normal. But even other cats may not have transient heart disease; they may still have HCM, but they may respond really well to heart failure. So do not quit on cats just because the heart looks horrible on echo, or their breathing is terrible and they look very, very poor, because the way they respond is completely unpredictable at baseline. So
yeah, I think I've given up giving people numbers. People want survival times, or they want to know what are the chances of survival. And I mean, I think it's important as the clinician that we have that conversation. We say, okay, well, we're worried about your cat for the following reasons, or we're not so worried. We think they'll respond well, or whatever. But I always stress to people, cats make it hard to give estimates. Because actually, I've, in the past, I used to use the word advanced heart failure. I don't use that in cats anymore, because that implies that they're on the brink of death. And I think the number of cases that you and I and innumerable cardiologists have seen where the heart looks awful on the echo, and you think, crikey, how is that cat upright and breathing, albeit breathing quickly? And then a year later, they come back in for a routine reevaluation. You think, oh my goodness, I thought you were gone. And here you are. This is fantastic. And I think, for me, one of the challenges with the transient myocardial thickening is those cats look so sick. Their heart failure is often terrible. They often present bradycardic, hypotensive. There's real feline cardiogenic shock cases. And it's not uncommon in the past for us to have to treat them with things like dobutamine, infusions and really intensive therapy. But often what you find with them is you're super intensive for 24 hours, and then they're just fine. And they just bounce back and do great. So they're quite amazing. And I've had cases where I think, I think this is a transient myocardial thickening. And then I see them 3 months down the line, 6 months down the line, and they're not. They're a cardiomyopathy with an HCM phenotype. And then I see cases that completely blindside me, that I think, it's a ragdoll cat. It's a 6-year-old ragdoll cat. I remember one guy, I think he's in the case series, who was a 6-year-old ragdoll, and he really looked like HCM. He had some systolic anterior motion. He's one of the classic breeds we think about for genetic, sarcomere-based HCM. And he went home, let's treat your cat's heart disease. And then he came back at 6 months for a routine re-examination. We hadn't even considered transient myocardial thickening. And there he was with a normal wall thickness and a normal left atrial size. And we just couldn't believe it. So really, they can blindside you. I think one of the big clues for me is very severe heart failure signs. As you say, a history of an antecedent event, often younger cats. But I think the troponins are often high, very high in those cases. So this is where cardiac biomarkers, they don't change my treatment, but they change how I think about a case. If I've got an acute, what looks like HCM phenotype with heart failure signs in a 2-year-old cat who's recently been anesthetized for a foreign body surgery, for example, we get a troponin of 20. The reference on most analyzers is less than 0.1. That would be a 200-fold elevation of troponin. That's massive. That would make me think, hang on, this isn't just a classic heart failure where we may get some elevation of troponin. This is an inflammatory condition, or something where we've got cell swelling, necrosis, something nasty going on. And I'd be thinking about myocarditis or transient myocardial thickening. So, as you say, Jose, I would just give them a chance. I think talking about the treatment of heart failure, acute heart failure, chronic heart failure, refractory heart failure in cats is definitely a separate podcast topic, and one where we can certainly seek some opinions. I think what'd be nice to do is, obviously being a podcast, we have a social media presence. What we're going to do is probably tweet a couple of articles and share a couple of pictures of discrete upper septal thickening, just so we've got an idea of what that looks like in our head, and maybe a left atrial fractional shortening, just for any of you who haven't measured that before, you can get an idea of what that looks like when one of us takes those pictures and does those measurements. So I think it's probably time to wrap up our first topic in the animal heartbeat. Jose, do you want to say some final words, some take-home wisdom for anybody listening to this podcast?
So thanks again for listening to our first podcast. So feline cardiomyopathy is highly prevalent. Most common heart disease in cats. Difficult to diagnose because some cats would not have heart murmurs and still be affected by cardiomyopathy. When they do have heart murmurs, loud murmurs are more likely to be associated with cardiomyopathy, HCM. Older cats, male, are more likely to be affected. So keep that in mind. Biomarkers, NT-proBNP might be very useful to screen for heart disease and decide which cats are more likely to have this condition. Don't forget that there are many diseases out there that mimic HCM, so we need to exclude them, namely high blood pressure, hyperthyroidism. And there are sometimes heart disease looks very nasty, and still cats respond very, very well to heart failure treatment. So just treat every cat you can, because sometimes it will be highly, highly rewarding. And feline cardiomyopathies are the best. That's what I wanted to say.
I think you've very beautifully, eloquently summed up the whole podcast in less than 1 minute. So that's I would agree completely with that. Fabulous. Thank you very much to everybody. Please follow at heartbeat_pod, and our Instagram is also heartbeat_pod. So we will be sharing some pictures of what we talked about in the podcast, and obviously we'll be sharing details of future episodes there. Stay tuned in the future and follow us on Apple Podcasts or wherever you get your podcasts from, and you can subscribe and stay up to date. Thanks very much.
All right, thank you.